We're going to start the first session on improving sepsis management. My name is Liewe Bos. I'm from Amsterdam.
My name is Katharina Boesel. I'm from the United States. Welcome.
Right, we have 4 excellent presentations today, and I would like to welcome the first speaker to the podium. First is going to present Mervyn Singer from London. He's going to tell us more about antibiotic therapy, how urgent.
Thank you, Liewe. Katharina. Hi, good morning, everyone. Okay, first slide. Antibiotic therapy, how urgent. Okay, I'll show this at the end as well, but basically I'm going to argue that for most patients you don't need to rush unless they're very sick, and by and large you have a window of opportunity to think a bit, and generally that's adequate and safe. Because in that window you can look and work out, well, do they actually have an infection or not? And you'll get some early results to hopefully guide, in inverted commas, best treatment. But on the other hand, once you've made the decision to treat, then don't delay unnecessarily. Give the antibiotics promptly. And antibiotics are not a panacea. So, yes, they're important, but think about, and you'll hear about later on, early adequate source control and good organ support. I put the beware sign up there because antibiotics are evil. They impact negatively on microbiota, immune functionality, mitochondria, organ function. So they may be a necessary evil. So we've got to take into account these are fairly toxic drugs. So clearly, if you're very worried that the patient has an infection or if it's obvious, then treat it, if it's treatable, that organism. However, there's no much point giving an antibacterial if it's a viral infection. So that's why this time window gives a little bit more time to actually reflect and think, and especially avoid them if no infection is present. So we had this propaganda, every second counts, need for speed. But if you look at the evidence base, it's not so compelling, as I'll show you. So clearly this was the paper from Anand Kumar a number of years ago that triggered the sort of propaganda campaign, which was beautifully nurtured by the Surviving Sepsis campaign. And if you read the paper, it was a retrospective analysis of 3 databases. A lot of the work was actually done by medical students. And you had this sort of implausibly straight-line relationship for mortality risk with every delay in giving appropriate antibiotics from the development of hypotension. And if you look right at the very bottom, essentially if you got to 24, 36 hours without giving the right antibiotic, you were dead. And I don't know about your labs, but mine tend to often not give me sensitivities for a couple of days. And certainly they're still alive often when the lab ring. Again, if you read the paper, they comment 22% of cases, so nearly a quarter, had no plausible bacterial pathogen isolated nor definitive radiological, surgical, autopsy or biopsy evidence of infection. Did they even have an infection? Don't know. Large number of patients. And again, in the paper, there was a survival rate of 52% if you got antibiotics before the onset of hypotension. And so that was actually a worse survival rate than if you got it in the first 4 hours after. So there was lots of plausibility alerts, but we saw that figure and we were taken up by the message. And I'm going to introduce you to the curse of the long straight line. And this is a mountain in Scotland. And this is the actual slope. This is the real slope. But what these papers tend to do, unfortunately, is draw a straight line from the beginning to the end. And if you look at the time of interest, the early antibiotic, you can see there's often quite a big difference between the real slope and the straight line extrapolated slope. Clearly, we've got to ask, when things are getting worse, why was there such a delay in treating these patients? I'll come back to that in a moment. And the other thing I'd like to just remind is that the patients don't suddenly fall ill. They've been brewing that infection. Sepsis has been developing over the day or two, or sometimes even longer beforehand. But time naught begins when, we think, oh, could this be sepsis? And they may have been waiting hours in the emergency department. This is a nice paper from a group in Boston where they looked at a large number of patients with septic shock, and a fair number, about 35–40%, presented with vague symptoms. These patients were older, sicker, had more comorbidities. The time to antibiotics was significantly longer. They had a much higher mortality rate. But when they did the analyses, basically it was this vagueness of symptoms that was an independent factor associated with mortality, but time to antibiotics wasn't associated with mortality. And they make the comment that the nature of the presenting symptoms, the ability to get a history out of, for example, an elderly confused patient who's not febrile, not got the sort of classic textbook signs, may have delayed the diagnosis and the treatment, and may be an important confounder in these epidemiology studies. This came out, this is a prospective trial done from Germany. It was an analysis of a cluster randomized trial to teach people to jump in there early, give bundles of care. But it didn't actually work. They couldn't show a difference. But this paper here, they looked at treatment, and I'm going to focus that red box at the first 6 hours, because that is, I think, the important time. And they found no difference in outcome comparing treatment within 1 hour to 1 to 3, 1 hour between 3 to 6. And if there were longer delays, there was an association with an increase in mortality. And again, just highlighting the fact that early source control was an important factor in determining whether the patient does well or badly. But you can see how that line, that straight line, extrapolates upwards. And so if there's a very, very long delay, there's a worse outcome for reasons I've articulated before. It may be the delay, but it may be the reasons for the delay that are important. And unfortunately, this straight line still comes up. Jonathan Freund is a lovely guy, runs an emergency department in Paris. This was published very recently. Again, another straight line. And they said, an increase in mortality if you delay more than an hour. But they've drawn out the line to 12 hours. But if you look at the more interesting 6 hours, there's no difference in outcomes. This is a nice paper from Hallie Prescott and Vinnie Liu. And it was a retrospective look at big databases. And they had 273,000 patients with community-onset sepsis, 48% of whom got antibiotics within a 3-hour window, and obviously 52% between 3 and 12 hours. And you can see this interesting difference. Those in shock were the ones who responded better in terms of outcome to getting early antibiotics. Those not in shock, there was very little difference, whether it's before 3 hours or between 3 and 12. Sharon Inav, another intensivist, and me, we got together with a whole load of infectious disease doctors from around Europe looking at specific conditions. So apart from sepsis, meningitis, lower respiratory tract infection, urinary tract infection, intra-abdominal infection, skin and soft tissue. And essentially the same message held through. You don't need to rush for the majority of cases. Probably you need to be urgent for septic shock. And the ID doctor were really keen on meningitis, although, again, separate talk. But when you look at the evidence, it's not that compelling. It's more emotional that you have to rush in with antibiotics. This nice paper came out from Nate Shapiro, Don Yealy, and others. It was a consensus-based report from American College of Emergency Physicians and others a few years ago. And they made the point that, again, the evidence base wasn't particularly strong, and so perhaps concentrate on those who are really sick, the ones with septic shock. There's insufficient data to sort of say, yes, give antibiotics within an hour to everyone. And likewise, this came from the Infectious Disease Society of America. Again, there's this push in America, SEP1, where you get reimbursed for doing this bundle, giving treatment early. And they said, focus on septic shock, because all that does, just throwing antibiotics at anything that moves, just encourages overprescription, resistance, etc. To be fair, the Surviving Sepsis campaign have recognised this, and this is the latest iteration that came out in 2021. And you can see here they acknowledge that the evidence for septic shock in terms of giving antibiotics within an hour of recognition, low quality of evidence, and sepsis without shock, very low quality of evidence. And their recommendation was, yep, if you're fairly sure it's sepsis, definite or probable, give the antibiotics without delay, ideally within an hour. Whereas if sepsis is possible, again, for those who are shocked, they're suggesting a 1 hour window, and if it's absent, you've got a 3 hour window before you need to think about giving the antibiotic. Certainly, again, just reinforcing the point, you don't need to wait till 2 hours, 59 minutes. If you think, yep, the patient needs an antibiotic, give it without delay. This is from the UK. We like to be a little bit different in the UK. And this is from the Academy of Medical Royal Colleges. This came out a couple of years ago. And basically it was from all the different colleges, you know, medics, anaesthetists, paediatricians, surgeons, etc., etc. And yep, the idea was actually to move away from this sort of sepsis, septic shock arbitrary cut-offs more towards the news score. So the news score, I'll come to that in a second, is very well embedded in the UK. And so our thinking was, why put sepsis on a pedestal? Why not treat it like you would treat any other sick patients? You know, the sicker they are, the more urgently you need to get people to the bedside. So this is the score. As I said, it's now well established in hospitals, in the wards, emergency departments. Increasingly, paramedics are using it, nursing homes, and increasingly general practitioners. And basically, the higher the score dictates the speed of response and who, in terms of doctor, nurse, etc., you get to respond to that patient. So it's a good way. It's not perfect by any means. None of these scores are, but it's actually been shown in multiple studies to be probably, at the moment, the best that's out there in terms of a bedside score to alert to the severity of illness of the patient. So very briefly, I'll just touch on a few highlights, and then I finished. We've split it into 4 bands, from a very low score going to red, 7 points or more. And clearly, you need to look at the patient, individualize your care. So if they're very rapidly deteriorating, are they immune suppressed, is there clear evidence of organ dysfunction? Again, that can prompt pushing up the patient to a higher category. And clearly, if you're worried, you know, they're immunosuppressed, neutropenic, whatever, you can then push them up to a higher category as needed for that patient. And clearly, we've highlighted right at the beginning, just try and make sure you know what the patient wants. What are their preferences? Because sometimes just throwing the book at them and doing everything, intensive care, etc., isn't necessarily in their best interest. So that is highlighted as an early consideration. And then depending on the banding, so if it's 7 or more, you should treat within an hour. If it's 5 to 6, you have a 3-hour window. If it's 1 to 4, you have a 6-hour window. And if it's 0, it's sort of standard practice. These are not sick patients. Again, stressing the fact these are maximum periods, not targets. And I won't bore you by going through all of that, but again, just emphasizing the point that it gives you a bit of time to get blood tests done, imaging done, etc., etc. Talk to microbiology ID if needed. Think about source control, all of these issues. Stressing the point, it's not to delay treatment, but to allow sufficient time to make an informed clinical judgment. And clearly, you know, you need to then review the patient regularly to decide, do they need to continue with antimicrobial treatment? If you find it's a sepsis mimic, it's not warranting an antimicrobial. And you've got to reach this balance. Yes, we need to do the right thing by that individual patient, but we also have to bear in mind antimicrobial stewardship. And good news, it's encouraging the clinician to exercise accountable judgment. So we need to be able to actually be able to think for ourselves rather than sort of brainstem following of a rigid protocol. And clearly we need to audit performance. I'm glad to say in the UK, NICE have endorsed that view. So the sepsis guidelines are being revised as we speak, and the antibiotics ones were changed to fit in with what I've just been talking about. So I wrote this with Mike Klompus and Thierry Thierry Calandre a number of years ago, but it's making the point that we should take a nuanced approach to treating patients with sepsis or septic shock. And that needs to reflect on the severity of illness and the certainty of diagnosis rather than one size fits all. I'll finish with this little graph. Essentially, y-axis, the certainty of bacterial infection, x-axis, the illness severity. So clearly, if they're not that ill, do they even need an antibiotic? It might be just removing a catheter, maybe. Watchful waiting, do some tests if needed. But as they're getting sicker and sicker, clearly if they're very sick, jumping quickly with an empiric, hopefully appropriate therapy. If you're sure it's an infection, run tests, seek advice. You've got this window of opportunity to try and get the best treatment you can, but again, avoiding unnecessary delay. And that intermediate thing, you've got a shorter time frame to respond, a 3-hour window. And clearly, if the patient is very sick, you are worried that it could be infection, then I think it is reasonable to treat these very sick patients. Timely, but not rushed. So I showed you this earlier. I'll finish there. Thank you very much indeed for listening.
Wonderful. Thank you so very much. I think we'll have a segment for discussion at the end of the session. Could we briefly ask, is Dr. Antonelli here? If not, Dr. Moskowitz, would you please come up and give your talk early? All right, thank you so much. We are introducing Dr. Ari Moskowitz, who will talk to us about metabolic resuscitation.
Good morning, everyone. Thank you all for having me. Thank you to the moderators. Thank you to the organizers. It's very bright up here, so hopefully it's a good view. My name is Ari Moskowitz. I'm from Montefiore Medical Center, and today I'll be talking to you all about metabolic resuscitation and septic shock, a bit of a different topic that I think we've heard so far. Trying to make this go forward here. There we go. I do some disclosures. I have some funding from the NIH, from the American Heart Association, and some consulting work for Aquestive Pharmaceuticals. So I want to start off, it's kind of funny to start off this way in a talk all about sepsis, but I want to start off by asking the question, what is sepsis? I think our understanding of what sepsis is has evolved considerably over the past 2 decades. When I was in training, it was really drilled into us that sepsis was this inflammatory process, an infection complicated by a severe response, a severe inflammatory response. And we were taught to use this, the SIRS-based criteria to identify sepsis. And I think our approach to this has really changed over the past 2 decades. And we now have moved to a more organ failure-based approach to sepsis, thinking that sepsis is a life-threatening organ dysfunction due to a dysregulated host response to infection. And we use more of a SOFA-based definition. And I think that makes a lot of sense. I love that this definition has this concept of a life-threatening disease, that we talk about organ dysfunction that's due to a dysregulated host response and not a normal host response to infection. But there's still a lot of questions. And I think a key one is, why do organs fail in sepsis? We define sepsis now by organ failure, but I don't know that we fully understand why organs fail in sepsis. Now, I think the obvious answer is that, well, we just don't have enough delivery of oxygen to tissues. This is the classic DO2 equation. We have your delivery of oxygen is equal to your cardiac output times your hemoglobin times your O2 sat and your dissolved oxygen. And we've done work to try to improve this. This is the classic Manny Rivers trial of early goal-directed therapy, where each individual step along this early goal-directed pathway was targeted at improving delivery of oxygen to tissues. We give inotropes to improve cardiac output. We give blood to improve hemoglobin. But is that the whole story? This is a study that I really like by Ronaldo Bellomo and his colleagues. That it's a little bit different. It's an animal study. We haven't done that much of that so far today. But it looks at what happens to the kidneys in septic shock. And what they did was they took sheep and they made some sheep septic. That's those little black dots on the leftmost graph. And they had control sheep. They also cannulated the renal artery and vein to look at renal blood flow. What you can see on the leftmost, I guess it's leftmost for you all, figure is time on the x-axis and arterial blood pressure on the y-axis. And clearly, as expected, if you have septic sheep, they have lower blood pressure. But what you also see is that those same septic sheep have equivalent renal blood flow as the non-septic sheep. They have autoregulation, and they're able to maintain that blood flow. Nevertheless, if you look at the final figure, the creatinine in the septic sheep gets worse. So why is that? They have theoretically the same blood flow to their kidneys, but yet they have worsening creatinine. And the authors conclude that in an ICU-supported model of gram-negative septic shock, early AKI was not associated with changes in renal blood flow, oxygen delivery, and they also looked at the histology of these organs, and that other mechanisms must contribute to septic AKI. And I think this histologic appearance is really important. What they found was actually a lot of apoptosis, not ATN, not tubular necrosis like you might expect to see with low oxygen delivery, but just apoptotic cells. So this is a classic New England Journal Review article from Derek Angus and his team looking at mechanisms of organ injury and sepsis. And a lot of it does focus on those classic things of vasodilation, decreased blood pressure, tissue hyperperfusion. But they do note this one little thing down here called mitochondrial dysfunction. Now, I'm going to tell a quick story from my first mentor, Michael Danino. I think probably many of you know him, who tells a story about when he was a medical student, and he was on the surgical wards as a medical student. And he had a patient that came in looking for all the world like he was in septic shock. The patient had organ injury, was confused, had low cardiac output, and new heart failure, and had a very elevated lactate. The lactate didn't clear with initial resuscitation, and the surgeons, being on surgical service, thought that maybe this was mesenteric ischemia. They rushed him to the operating room, and they opened his belly, and intestines looked totally fine. Brought the patient back, and my mentor, who was a medical student on a surgical rotation, and they're the only ones taking a full history, went and got a better history for this patient and found out the patient was an alcoholic, and that maybe the patient was thiamine deficient. So they started thiamine for this patient, and the lactate cleared very, very quickly. Patient recovered very nicely. And that's what really started this sort of pathway that I've now been on, thinking about, maybe there's more to organ injury and sepsis, and maybe part of that story is mitochondrial dysfunction, and maybe part of that mitochondrial dysfunction is related to thiamine deficiency. So thiamine, vitamin B1, interestingly enough, in mammals, most mammals actually make their own vitamin B1. Humans don't. We have to replenish our vitamin B1 every 2 days. So you can envision a situation where Dr. Singer just showed the 48 hours before sepsis. When you're not eating, you're not drinking very much, you can rapidly deplete your thiamine levels. And why is thiamine important? Well, this takes us back to maybe medical school, where you have your glycolysis going from glucose to pyruvates, and then through pyruvate dehydrogenase, PDH, and down through the Krebs cycle. And you need thiamine to do that, because thiamine is a key cofactor of an enzyme called thiamine pyrophosphate. That's on the left. And if you don't have that, you shunt over to lactate formation. Thiamine is also key for transketolase, another enzyme that's key for the pentose phosphate pathway that helps with the clearance of reactive oxygen species. So there's some real biological plausibility and important roles that thiamine is playing in the body that may have an importance in sepsis. And we did find this when you look here at PDH activity on the y-axis, control patients, and then septic patients on the x-axis. You can really see in sepsis a dramatic decline in PDH activity in sepsis. So we thought this was interesting, and this and some other studies that we did led us to our first phase 2 randomized trial looking at this question. This is back in 2016. We ultimately studied 88 patients, 43 randomized to the thiamine arm and 45 in the placebo arm. And what we found with our primary outcome of lactate, it was one of our correlated outcomes, it was a phase 2 trial, was that there was no difference overall for the complete group. You can see lactate over time in that first graph there. But what I will point out is if you look at those red bars, which are the placebo groups, there's a lot of outliers in the placebo that you're not seeing in the thiamine groups. And maybe those are the patients who were thiamine deficient and didn't get thiamine and therefore had these higher lactates. And when you restrict the cohort to just those patients who are thiamine deficient, which is about 30% of this cohort, there was a difference in lactate with patients who were thiamine deficient but did not get thiamine having higher lactates overall. I will note that while we found about 30% thiamine deficiency in this cohort, it was a very select cohort. It was patients who came in with a lactate above 4, got resuscitated, but then still had a persistently elevated lactate, perhaps selecting out those patients with thiamine deficiency. Looking at mortality, again, we didn't find on this left graph any difference in mortality overall. But when you restrict to the thiamine deficient group, there actually is a difference. So if you were thiamine deficient and you didn't get thiamine, you were more likely to die. We took the same data and we did a sub-study looking at renal dysfunction. And if you look here at the bottom row, you can see that 3.2% of patients who received thiamine needed renal replacement therapy compared to 20% of those who did not get thiamine. And that led us to our second randomized trial, which we recently published, which again, about 90 patients. But this time really focused on the renal question because we found that the kidneys seemed to be the ones that were most vulnerable to thiamine deficiency. What we found was that the patients who received thiamine tended to have lower creatinines overall, although not quite significant, at 0.07, but slightly lower creatinines, but also a lower rate of need for kidney replacement therapy and lower KDIGO3. While those were not statistically significant, although close, there was a difference in ICU-free days favoring the thiamine group, where patients who got thiamine had more ICU-free days than the non-thiamine group for the overall cohort. But now, taking a look at the thiamine-deficient cohort, we look here at renal failure in both groups. So on the left, you have renal failure in the full cohort, and on the right, you have just the group that is thiamine-deficient. And you can really see that there's this greater effect in the thiamine-deficient patients, where if you're thiamine-deficient and you don't get thiamine, you are more likely to have renal failure. Taking these two trials together, we published this recently, sort of a patient-level meta-analysis of these two trials. This first one here is the alive and renal replacement therapy-free. And you can see that the right is the odds ratio that favors thiamine, the left does not favor thiamine. And you see that overall, if you receive thiamine, you had a 2.05 higher odds of being alive and free of renal replacement therapy, but dramatically higher if you were in the thiamine-deficient group. You can see here that 84% of patients in the thiamine-deficient group who got thiamine were alive and RRT-free compared to 37% of the placebo group. So some pretty dramatic effects, especially for that thiamine-deficient group. And then looking here at maybe a dose-response effect, if you look at the bottom where those colored little boxes are, you can see that taking dose response, that the effect of thiamine seems to be greater. So if you have a thiamine level of less than 8, and that's like the Quest diagnostics that we use for our thiamine levels, level of deficiency based on sort of a normal curve, you can see that patients who were thiamine deficient who got thiamine did a lot better than patients who were thiamine deficient and did not get thiamine. In sort of a moderate level, this like thiamine 8 to 12 group, so patients who were on the lower side of normal, there was still an effect, 68% versus 57%. And then in the patients who had high thiamine levels or normal thiamine levels, there was really no effect at all. So you have this dose response, which again, I think adds to that biologic plausibility that we've been talking about. So where do we go from here? Our next step is, I think, a randomized phase 3 trial, a much larger trial. But it brings up a lot of questions. Who do we enroll in this trial? Do we enroll all patients or just those with thiamine deficiency? And if we are going to enroll patients just with thiamine deficiency, how do we do that? How do we know at the point of care that this patient's thiamine deficient or not? In current state, we have to send our blood samples out to Quest. It takes 3-4 days to come back. That's not really tenable for a randomized trial. We can do some prognostic enrichment. It turns out that low albumin levels tend to be very predictive of a low thiamine level. So 34% of those patients with an albumin less than 3 were deficient compared to 22% overall. So that seems to separate. So that's one possibility, or developing a score around that is one possibility. Or using these sort of newly developed lateral flow assays, which we're working on developing as well, that can maybe sort of like a COVID test to detect patients qualitatively who are thiamine deficient. And we're working on that angle too. So just some take-home messages. Septic shock is defined now by this presence of organ injury, which I think is a real advance over our prior definition of sepsis, really focused on inflammation. But we don't know why most patients develop organ injury in sepsis. Certainly part of it is because of failure of delivery of oxygen. But I think a lot of it might also be mitochondrial dysfunction. Now, there's a lot of what we call mitochondrial resuscitators that are out there. There's review articles that look through a lot of them. Thiamine is just one. but one that we've been really interested in, and we think is interesting because it's essential to a lot of our cellular aerobic respiration. And we found that deficiency is very common in septic patients. And again, because mammals, while overall tend to make their own thiamine, humans don't. And we tend to deplete our stores very quickly if we're not taking an adequate PO intake. We found in 2 randomized trials that thiamine supplementation may improve organ injury and septic shock, but especially in patients who are thiamine deficient. And a key next step is how do we identify these patients at the point of care, or do we need to? Or should we be giving thiamine more broadly for patients who come into the emergency department? That's what I have. Thank you all for your time.
Thank you very much, Dr. Moskowitz. So you probably noticed that we skipped the presentation of Dr. Antonelli. This is because he is currently taking care of the Pope in Italy and wouldn't be able to make it here. So we are a bit ahead of time, and we're going to move to the last presentation. So Dr. Matthieu Komorowski is going to talk about AI decision support, and then we will have sufficient time for discussion afterwards, so please stay.
All right, good morning, and thanks so much for having me. So yes, we're going to talk about sepsis management, but particularly how could AI help us treat those patients. So these are my conflicts of interests. All right, let's think in terms of sepsis patient pathway. Right, those patients come to the hospital. Usually they go through A&E, they get triaged, then they can be admitted to the ward, or they can be discharged straight away. Some of them go to ICU straight away. Some of them go to ICU after having been to the ward. When they're on the ward, they can be reviewed by our critical care outreach teams. When they're on the ICU, they receive some kind of organ support. And eventually they discharge or they don't. So the question is, where could AI help us along this pathway? The answer is easy. You just have to ask no one else but the Surviving Sepsis Campaign. Here's a paper that I find fascinating, just a year old, the research priorities from the Surviving Sepsis Campaign. Top 5 research priorities. What do they say? Can we use predictive models to predict sepsis? Can we qualify organ dysfunction in sepsis? And then, how can we individualize fluids, vasopressors? Last point, how do we deliver personalized / precision medicine? So the top 5 research priorities of the Surviving Sepsis Campaign scream of ML, AI, machine learning, left, right, and center. I think it's a fascinating take. All right, back to the sepsis patient pathway. So where does AI could fit on that on this slide? Well, sepsis prediction, I would argue that we can do that all along the pathway, even potentially before ED, A&E admission, right? If we had data, we could do this. Triaging. Predicting deterioration on the ward. The patients, when they're on the ICU, we could probably predict who's going to need some organ support. AI can help us with treatment, can help us find the right indication for drugs, the right timing for these drugs, and the right dosing, potentially. So here, just a few examples, maybe antibiotics, maybe fluids, maybe vasopressors. Wouldn't that be good? Finally, if we want, we can use AI, we can use machine learning to predict mortality, length of stay. Whether we think that's useful or not, that's clinically useful, that's a secondary question. So lots and lots of potential applications. Let's look at examples. Can AI predict patient deterioration and help us with triaging in ED? Maybe. Here's a very recent paper, interesting. It's a pre-post design, so pre-deployment, post-AI deployment design. Large number of patients. The input data that the model uses is everything you would expect in this application. And basically, they had nurses, triage nurses, having to rank the patient into 5 categories of a score, an emergency severity index, ranging from 1 to 5. 1, the patient is very, very sick. They need to go straight away to the ICU. 5, they can probably go home. Okay, and the nurse did this before and after, without first, and then with an AI decision support. The interface looked like this. I hope it's readable, but it's quite straightforward. What you see is the interface that the nurses had access to when documenting this score, and you see near the top the AI triage recommendation, the score, the category suggested by the AI. What did they find? Post-deployment, the number of low acuity patients increased, so patients were reclassified as lower severity. The number of patients with high acuity actually decreased. They report a number of good, interesting metrics related to timing, faster time to assessment, faster time to ED discharge. Very interestingly, the patients in the highest severity category spent a lot less time waiting to be sent to the ICU. So remains to be seen what the impact of a tool like this on patient outcomes, but in terms of workflow, potentially very interesting. Sepsis prediction, the second big task that we ask AI to achieve. There's a ton of sepsis prediction papers out there. This one is nearly 3 years old now, but to my knowledge, that's the largest that we have. Nearly 600,000 patients monitored by a sepsis AI alert. The alert flagged on about 7,000 patients. Now, they did not randomize. This is not an RCT. They split those patients into 2 groups depending on whether the alert was confirmed by a healthcare provider or not. So with this caveat, the study is still interesting. There's an interesting signal, a reduction in mortality observed, better SOFA progression, and a shorter length of stay in the group where the AI alert was confirmed by the healthcare provider. Okay, interesting. It's not randomized. Another more recent sepsis prediction model. This is another one of those pre-post design, a deep learning model to predict sepsis. On the plots, I added this red line vertical to show you the intervention date when they deployed the AI. 6,000 patients monitored in 2 different EDs, and what they found is an increase in sepsis bundle compliance. Whether that's good, that's for another talk. A decrease in hospital-related sepsis-related mortality. And you see the bottom chart on the right, what seems to be a faster recovery from organ failure as measured by the SOFA score. So again, an interesting signal. Mervyn talked about antibiotics in sepsis. Wouldn't it be amazing if we didn't have to wait for 3 days before knowing the sensitivity spectrum of your bug? Well, maybe machine learning can help us do that. You can amplify the genome of bacteria that you find in the blood and then predict the resistance profile straight away from whole genome data. This is one of the papers doing this. I'm still not sure why this is not a huge research effort and why we're not seeing those tools popping up in clinical practice, because in my opinion that would be a complete game changer. We would reduce the number of patients receiving antibiotics, receiving the wrong antibiotics, receiving broad spectrum antibiotics when they don't need it. We would most likely reduce antibiotic resistance drastically if this was available at the point of care, in a matter of hours. Mervyn told us that we had time to wait for a few hours for most patients, unless they're shocked. I did pay attention. 2025, of course, we have to talk about ChatGPT, large language models. We wrote this editorial 2 years ago as a quick overview about what this could be useful for. It's been at least 2 years that large language models are. I like the silence. So we're all very anxious about large language models, right? And whether we're going to lose our jobs. It's been over 2 years that these models can actually pass medical tests. Medical exam. This is USMLE, and now they can give nearly a perfect score, way greater than the average applicant. How does that translate into real world data? Well, maybe we're still okay so far. This is a study looking at testing 5 different LLMs on clinical notes from patients presenting to A&E, to ED, with an acute abdomen. And they had diagnoses of appendicitis, cholecystitis, and so on. What they found is, so the green bar is human doctors, the rest is LLMs. You see that they perform significantly worse than clinicians in diagnosing, What's even more worrying is that they don't follow diagnostic and treatment guidelines, especially when the patients are very sick. And if I can just bring your attention to the leftmost part of the plot, you see antibiotics recommendation in acute appendicitis. Those models recommended antibiotics less than 25% of the time. So we still have a bit of time. I think these models will get there, but not just yet. Okay, we heard about sepsis, sepsis heterogeneity, the challenge in disentangling this heterogeneity. I like this editorial that says that we should put this at the foundation of our research efforts rather than considering this as an afterthought. Of course, in this area, the area of sepsis phenotyping, we have to reference this work, Chris Seymour's phenotypes, using routinely collected data. So this is vital signs and lab tests, and then you ask an unsupervised machine learning to give you 4 groups, so that the groups are as homogeneous as possible within the group and as different as possible between the groups. And you get this, quite a descriptive work so far, but potentially can have useful clinical applications. And this is just one example. It is a modest paper, a reanalysis of patients from the process trial. You remember this EGDT trial. And what they did, they split the patient data, so they used clinical variables and biomarkers into 2 groups. And what they found is that you can very easily identify 2 groups. What they found is an association between the intervention, so EGDT, and mortality in one of the groups, not the other one. So just really to illustrate that by using clustering and unsupervised learning, you can split patient data from randomized trials into groups that are homogeneous, and then you can sometimes discover an association between the intervention and outcomes in a trial that was initially neutral or negative. Transcriptomics, we have to talk about this, of course. Here is one example of some work done by Tim Sweeney with also the company Inflammatics, and they have a panel of transcriptomics of messenger RNA that allow you to differentiate between bacterial, viral, or no infection with good sensitivity and specificity. I mentioned this one because, to my knowledge, they are now FDA approved, and you can work with this device that provides you a bacterial score, a viral score, and even a severity of illness score. The last type of machine learning models I want to mention is reinforcement learning, where what we do here, we model a decision process and then we optimize it for a predefined reward. Okay? Reinforcement learning is exciting because it is the perfect framework to allow us to move from predictive AI to actionable AI. Predictive AI being, the patient's likely to develop sepsis in 12 hours. Actionable AI being, what do I do now? Do I start vasopressin? Do I give a fluid bolus? Do I start antibiotics if I want to improve the patient's outcomes? There's a ton of published proof of concepts using reinforcement learning that are applicable to sepsis and critical patients at large. For example, sepsis antibiotics, the settings on mechanical ventilation, steroids. This is insulin in diabetes. This one has a small pilot study, prospective pilot study. Fluids and vasopressors, there's quite a few papers in that area, and even renal replacement therapy timing work in which Stéphane Gaudry was involved. All right, so where are the bedside applications? Do you have any? I don't. In my hospital, we had a sepsis prediction score built in Cerner, and it would alert 100% of the time. Highly, highly sensitive, not specific at all, completely useless. This paper is now 4 years old, but the signal is still the same. They reviewed nearly 500 AI applications in the ICU. 500 models. And what you see is that over the years, most of the models are still at the stage of early prototyping, early model development, very little prospective validation, very little deployment in clinical workflows, very little assessment of validated medical devices. So this is what I'm working on in my academic work in London. This is a picture of some members of the team, and you see it's highly, highly multidisciplinary. We have a lot of machine learning experts, clinicians. We work very closely with the NHS informatics team. We have human factors experts, medical device development experts, people who work in health economics, clinical trial manager, and so on and so forth. This is the kind of team that's necessary, I think, if we are to try to crack this complex problem of AI deployment. And what we do, we follow this actionable AI assessment pipeline. We've not developed this, but it sort of makes sense when you think about it. The idea is that you have to conduct a series of studies that have an increasing level of fidelity, but also an increasing level of risk, and you only move forward when you're satisfied with step 1 before going to step 2 and so on, with the end goal of conducting clinical trials. So my conclusions, I think indeed AI could potentially help us treat those patients, disentangle sepsis heterogeneity, identify who is likely to benefit from a given intervention at a given time. Maybe. 2 questions. Which of all those applications will eventually demonstrate a positive effect at scale, clinical utility, improve patient outcomes, improve clinical workflows, improve healthcare delivery, cost savings? Right? It's not guaranteed at all that we'll see this. Last question, how will we as a research community interact with the industry to translate some of this work into eventually what needs to be regulated medical devices, right? That we can trust, that we can install in our hospitals, and so on. Thank you so much.
Thank you very much. I would like to invite all the presenters to the stage to answer questions from the audience. If you have a question, please raise your hands and you'll get a microphone from our 2 colleagues. Maybe here in front, please, Professor Torres.
Thank you very much for your talks. Can you hear me? Yeah. Now, one variable that I think is associated with a poor prognosis, and I don't know if it's included in these AI systems, is the time from the initiation of the disease to the first emergency department. Because usually intensivists don't look at that. But I think it is very important, and it's very easy to know, because the relatives can tell you.
Imagine that's for me. You're absolutely right. What happens before hospital admission, before ICU admission is crucial. The problem is that very often this is not captured anywhere in a structured form that we can use to train those models. Yes, you can ask vaguely, the time of disease progression before the patient turned up into the hospital, but very often that would be missing or unreliable. And unfortunately, we have to rely on what's available in the data, which is very, very late, very often, right? Very often, actually, if you use ICU data, you have not captured sepsis onset time most of the time, and that's a big problem.
Any other questions? I have a question for Dr. Singer. Dr. Singer, in your approach of potential consideration of watchful waiting, how do you differentiate between community-acquired and in-hospital acquired sepsis?
I don't.
Do you watchful wait even in the hospital?
Yeah, because a lot of the time they're not ill. They might have a bit of a temperature or a bit of green phlegm, whatever that means. And so if they're not ill, you can keep an eye, watchful wait. If you're worried about a cannula or whatever, take it out. But then you can watch, and you're monitoring them. So if there is deterioration, again, we use the news score in the UK, but a score, then, jump is appropriate. But it sort of stops you from sort of automatically just throwing antibiotics at that poor patient, especially if they don't need it, especially, as I mentioned in my talk, with the toxicity that we don't often recognize with antibiotics. Thank you.
Thank you.
Thank you very much. There's a question over there in the middle. Please state your name.
Jakub Śmichowicz, Wrocław, Poland. I have a question to Dr. Moskowitz. Should we give thiamine to all our ICU patients? In what dose and for how long?
Yeah, I think it's a great question, one we get asked a lot. And often one of the downsides when I give this talk is that everyone gives thiamine and we can't study it anymore because it's low cost and seems to be safe. The answer is I don't know. I truly think it probably does benefit patients who are thiamine deficient, and I think if you knew someone was thiamine deficient, you would probably give it to that patient. Most patients in your ICU are not going to be thiamine deficient, and we've seen from prior talks today that sometimes doing things for patients who it's not going to benefit, it's just going to lead you down a wrong course and distract from other things. So I don't think it's really ready yet for prime time for every patient. I would give it to patients who do display risk factors for thiamine deficiency. To me, that's patients with low albumin, patients who appear malnourished, patients who weren't taking in good oral intake in the 48 hours before they come in, and then especially patients with high lactate levels that don't seem to be clearing. Those are the patients who I would think about giving thiamine for. In terms of the dose and the duration, we don't know. Actually, my mentor, Mike Danino, who got me into this in the first place, tells this great story about how he was trying to figure out where the doses come from for thiamine, and found out that the person who came up with the dose of thiamine actually lived in Boston, where he was practicing, and he went to his house. He was a 100-year-old physician, and he asked him where it came from. And he said, we were rounding, and one of the medical students said 500 milligrams. And I thought, that sounded good. So that's where it came from. So there's really no good dosing. For our trials, we do 200 milligrams twice daily. It's not as directed at the CNS, which we think might require higher doses, but we have shown that the 200 milligrams twice daily dramatically increases your thiamine levels almost immediately. And often the patients in the hospital with the highest thiamine levels are the patients with alcoholism or alcohol use disorder who have very, very high thiamine levels, even just from one dose of thiamine administration. And then we typically do it for 3 days after they arrive. But honestly, after that first dose, the levels are very high very quickly.
All right. The questions from the audience. Maybe I can ask a question to the three of you. In the last presentation, we saw that there are a lot of prediction models being developed, and maybe machine learning has become too cheap to do. It's very easy to develop. To develop a drug is a lot of work. To develop a machine learning model is quite easy. You publish well, and then they are frequently not developed into clinical application. So my question is, how do we make it more costly to develop these models, or make it easier to validate them and to do prospective randomized controlled trials to actually assess their impact?
Yeah, thank you. It's a great question. I think one reason why your question is about conducting randomized trials and how do make it easier to do this?
No, so I think in your flowchart, at the end of the flowchart, there was randomized controlled trials to assess the impact of outcome, right?
Yeah.
And I think none of these models have reached this state, or very few. So.
Very few, but maybe it's a good thing, because if we think about what happens in the pharmaceutical industry, those big companies start with thousands and tens of thousands of molecules and drug candidates, and then they get screened in a safe way, right? First, I guess at the cell level, and then animal models, and then healthy subjects before moving on to patients. And only when we're confident that it's safe and effective, those drugs are approved for clinical use. And I think we should follow the same process, and that by definition takes time and money. And I think that's one of the reasons why we don't see a lot of randomized trials, but hopefully with time some of those models will trickle down this pathway and eventually be approved. There are a few trials that are actually quite worrying that show increased patient mortality. For example, a Wilson BMJ paper in 2021 showed just an AKI alert nearly doubled the mortality in patients in non-teaching hospitals. There's an interesting paper on AI in radiology showing that there's heterogeneity of effect, and some radiologists actually do worse when they use an AI system. They're less accurate, they make more errors. So we have to be careful and take it in a stepwise fashion.
Yeah. Thank you. We have a question right here.
Dr. Sarkar from Kolkata, India. In sepsis, we are losing patients every day, and still mortality from 25 to 40%. And we have been having different opinions, gradually changing pendulum from one end to another end and going back to, again, other end. So do you think that all these are going to change management, or there is something inside which we haven't been able to identify, like genetic background, which, for example, in diabetic, all diabetic are not having organ failure, but there are some background which is causing. So is there anything missing still, that genetic background we haven't been able to identify, which if we can identify, and then we can say from like AI or somewhere straight away that this guy is going to behave abnormally?
Thank you very much. A few comments. If you go back to the 1970s and look, why did people die of sepsis, or when, I should say, it was usually within the first few days. So one of the triumphs of modern intensive care, we can prolong death. To be fair, I think outcomes have improved, and I think a large amount of that's the recognition, less iatrogenic harm, etc. But what we've done successfully now, we can get them through the acute period, but they don't often then recover. And then I call it therapeutic fatigue. They're there, they're not getting better, they get an infection, they've deconditioned, etc., they die. So I think, a large amount of the effort in research has been front-loaded. Give them an a cytokine blocker or whatever early on, early goal-directed therapy, all of these things early on. But I think we need to actually focus on trying to accelerate recovery, and whether it's the mitochondria or other things. But I think, that to my mind is where we can make a difference, because the other quite frightening thing is also you can actually predict outcome even in the emergency department with a fairly good degree of accuracy. So if that's the case, people are predicated to live or die very early on. So clearly the challenge is those who are predicated to survive, we want them to survive quickly without morbidity, especially long-term morbidity, and get them out of hospital quickly. Those who are predicated to die might well stay in hospital longer, but we need to then find what can reverse that poor prognosis. I don't know if you guys want to...
I completely agree. I think one thing, Dr. Shanks talked about it before as well, which is the concept of attributable risk. And how much are patients dying because of sepsis, and how much are they dying because they have advanced cancer and there's not much you could do. I think we don't fully understand. You said mortality is still 25 to 40%. I don't know what sepsis mortality should be, because some patients are going to die. They're going to die of infection. I don't know where that line is, and I don't know how to figure out exactly who are those ones that we should be treating aggressively up front and getting them to recover faster, and who are the ones we should be de-escalating on and pulling back on earlier. I think that's sort of the question that we need to be asking ourselves.
Can I add just a quick point to what Matthieu was saying, and I'd be interested for Matthieu's comment just apropos of your last question. No, one of the problems of AI is that it's based on the model, on the information that you have, and time and again, well, very few have actually gone externally for validation, and time and again the models have failed, often because the data that the model was based on is incomplete. Do you think that's the issue? Because, dare I say it, the classic one, I think, I'll be rude to Epic, but was it St. John's one, which lots of American hospitals bought based on no data, and we were one of the first in the UK to have it. When the hospital said, should we buy it? And I said, no, wait till it's validated externally. And then a few weeks after that, a paper came out, I think, was it Johns Hopkins or wherever, showing it was 12% accurate.
It's a great question, and what the question it raises is whether generalizability is a thing, whether it is possible to train a model in the US and use it in the UK. Leo Selly has an editorial, that's the exact title, The Myth of Generalizability in AI in Healthcare. And so that means that the other option, the other solution is to retrain models locally. And that might be a very high bar for most places to have access to exactly the same data in quantities that are sufficient with the in-house expertise to retrain the model, and then the regulatory aspects of doing this is very, very muddy as well. Huh? It's very, very unclear. So yeah, these are complicated topics.
Yeah, we just to that point, I don't know how much time we have, but there's someone to speak. But we recently developed an ML model to predict CLABSI, central line associated infections. And we actually found in our model making that having a femoral catheter was actually quite protective of CLABSI. And we asked why, and it's because locally we have a very aggressive policy of getting those lines out very early, and we're much more careful about those lines. And if we had used a generalized model, it wouldn't have worked for us. But because we developed the model internally, we don't use that, femoral line insertion. And that's why I agree with you. I think it's important to train locally for these reasons.
All right, other questions from the audience? And maybe a last question from me to finish off. So in the last presentation, there was one of the models that was presented differentiated between bacterial and viral infection and between moderate and severe infection. So based on the first presentation, is this the way to go to sort of formalize the actual risk of the patient of having a bad outcome and having benefit from antibiotics? Or should we stay with the clinical features that we can readily observe? Which of those two has more potential?
I think, Ari and Matthieu can give their comments. I think one thing these studies haven't taken into account is clinician behavior. What will make a clinician do something or not do something? And my worry, and I've told Tim Sweeney on the inflammatics thing that Matthieu was showing, that if you give a risk, what sort of risk is a junior doctor in the middle of the night in an emergency department going to be happy to take to not treat? So if you say, oh, there's a 25% chance, that means 1 in 4 I'll get it wrong. And then my boss will throw the book at me in the morning. So that's the problem with, risk. Risk is balanced with, obviously, clinical gestalt and experience, I think, comes into it. So my worry is that not enough attention is being paid to how the clinician will respond to the information. So, and again, there's a lot of discussion. I think rule-in and rule-out tests. I think a rule-in test is easier to rule out something just because you don't find it, or there's a 1 in 4 chance. I think a lot of clinicians, especially junior docs, are not going to follow the instructions.
But isn't that argument true for the Mu score as well? Like, your tolerance may be different.
But I think that's the whole point. I think we've got to re-educate. Unfortunately, and for all the good intentions of surviving sepsis, etc. So I don't want to detract from that. But it drove home this message that you've just got to do everything to everybody, regardless. And now I think we've realised that the majority of patients don't need that sort of aggressive approach. And we've got, obviously, the spectre of antimicrobial resistance and all the covert problems in the individual that we don't see. So I think we've got to be more considered, and I think we've got to engage our cerebral cortex a bit more rather than blindly following protocols. So I think, I made the point in my talk about exercising clinical judgment and accountability. And I think we're losing that, or we've lost that in the last 5, 10, 15 years. And I think we need to sort of try and reclaim it. Please.
Yeah. To your point about the transcriptomics sepsis prediction, I think exactly along the lines of what Mervyn is saying, designing a technology, designing a machine model is easy, but designing a human AI tandem system is complicated, and there's so much randomness in that system that it becomes really hard to design, really hard to design a solution that will work everywhere in the world if that's the ambition of the technology, really hard to assess. So yeah, again, complicated topics, but I agree very much with Mervyn. The solution is to leave the clinician driving the use of those technology with our clinical training, with our understanding and the liability that comes with it, right?
Yeah. Can I quickly jump in before Aaron? But the thing that I'd add to that is document why you've made that decision at the time and explain, I don't think an antibiotic is suitable in this patient for X, Y, Z. Because often there's the fear of medical legal implications, and that's often because things aren't documented. Why did you do something? Who cares if the temperature is 38, whatever? Why did you not give an antibiotic, or why did you do an action? And so you can contemporaneously justify what you did, which shows clinical judgment. And, we all get it wrong, myself included. Nobody's perfect. But again, if we can explain why, justify why we did what we did at the time, I think that's good enough. Sorry, Eric.
No, I agree with everything you're saying. I think the big flaw that I've seen that it sounds like your group is really doing well is not pairing up that clinician in the room with the scientist designing the models, designing the approach to the models. I think when that gets lost, then the models become useless. And I think that having that pairing is just really key.
Okay, so I appreciate that we still need an expert clinician in the room. I'm also glad that Merv is volunteering to be the senior physician on call in the night in the NHS.
The AI physician.
So with that, I would like to summarize this session. I think we can withhold antibiotics sometimes. Only in the most severe, we need to be as quickly as we might have been in past years due to the guidelines. We might need to give thiamine to patients who are thiamine deficient. And AI is promising, but still very, very complicated. With that, I would like to end this session and see you after the lunch in the next session.
Thank you, Matthieu. Thank you.